Here's what you missed on empiric antibiotics. On the last episode of empiric antibiotics, we treated a Klebsiella-producing carbapenemase, or KPC organism, with ceftazidime avibactam, and our original clinic patient Cece is improving. Yay! But how would this case have gone differently if she had a beta-lactam allergy? After all, we used at least one beta-lactam antibiotic each step of the way. Before we get to the answer, let's start with a question. What do you do when a patient comes in and says, I have a penicillin allergy? Well, the devil's in the details. First, we need to assess for signs that they had an immediate allergy. Were there raised, itchy spots consistent with hives or urticaria? Was there any swelling of the mouth, eyes, lips, or tongue, suggestive of angioedema? Were there any respiratory or hemodynamic changes, suggestive of anaphylaxis? How was the reaction treated? An EpiPen, Benadryl, hospitalization? It's also important to keep the following in mind. Just because a relative had an allergy to penicillin does not mean that your patient will. Don't forget about possible serious delayed reactions as well. Type 4 hypersensitivity reactions are no joke. You also want to check, and this is where the EMR comes in so helpful, check to see if they've received similar medications in the past. If someone says they are allergic to penicillin, but they just got a course of Zosyn a few months ago without a problem, it's highly unlikely they have a penicillin allergy. Before we discuss management, keep in mind that most penicillin allergies are either not real or patients have grown out of them. 10% of the population reports a penicillin allergy, but less than 1% of the population is truly allergic. And most patients who have a confirmed penicillin allergy will require a cephalosporin or carbapenem, given the differences in side chains. This is such a problem that some hospitals even have an allergy team that does penicillin skin testing. So what do we do if our patient has a history of a mild reaction without features of a serious immediate allergy? Well, you could do penicillin skin testing if it's feasible and available. You could give a test dose of a penicillin or first or second generation cephalosporin. Of course, you would only want to do this if you were really doubtful about the allergy and or its seriousness. You could, if it were appropriate, give a third or fourth generation cephalosporin or even a carbapenem. And of course, you could give a non-beta-lactam antibiotic. So how does this change if we do have a history of a reaction with features of immediate hypersensitivity? Again, we can do penicillin skin testing, but we are not really going to want to test dose a penicillin or first or second generation cephalosporin. Perhaps, and we should definitely talk to allergy here, we could do a test dose with a third or fourth generation cephalosporin or a carbapenem again, recognizing that it's slightly more risky depending on the seriousness of the allergy. And yet again, we can give a non-beta-lactam antibiotic. Now, if a penicillin absolutely needs to be given, for example, we have a pregnant patient with syphilis, the patient can undergo a desensitization protocol in consultation with an allergist. So what happens when you can't verify the allergy? This is unfortunately the case in many circumstances, and it's a bit of a gray area. In most cases, we end up treating the patient conservatively as if they did have a past immediate allergy. Okay, so let's say you have a patient with a penicillin reaction with features of immediate hypersensitivity. You cannot do penicillin skin testing or a test dose. You have a patient who is sick, and we certainly need to put them on something, just like Cece was. One option is Aztreonam. Aztreonam is a monobactam without a bicyclic ring, so it does not have cross-reactivity with penicillins. It has broad gram-negative coverage, both respiratory and enteric, and it even covers Pseudomonas. But we should note that it really doesn't cover anything else. Nada. No gram-positive, no atypicals, and no anaerobic coverage. It's not like most beta-lactams where you at least get strep and usually some MSSA coverage. So empirically, we always have to pair it with another agent if we need gram-positive coverage. So think of Aztreonam as a gram-negative agent with a caveat. Pseudomonas can still be resistant to it, and it won't work for ESBL or AMP-C producing organisms. So are there other agents we can use besides Aztreonam if there's a penicillin allergy? I'm sure there are, and we'll talk about it on the next episode of Empiric Antibiotics.